Welcome back to Brain Pods. We are at the very end. This is now May the 4th of 2018, and I'm excited about this because it's taken about 6 months to put these together. Dr. Sonia Wang is here, who is going to talk about some pediatric neurology.
Yes.
I was so excited to have Dr. Wang come in, and she immediately took a look and started rattling off all of her favorite Game of Thrones characters.
So don't feel obligated to watch all the Game of Thrones.
And for those of you who really hate the show, I'm sorry.
It's not going to affect your grade.
It's been a long road. But we're starting. The new curriculum actually starts next Monday. We're really looking forward to having you come and join us. That being said, we're just going to roll right into it. So here we are. This is just an introduction to pediatric neurology. We're not even going to get a chance to talk over some other really cool things that we talk about in other brain pods. What I think is most exciting thing in all of neurology is some of the gene therapies for like spinal muscular atrophy. Take a look at that brain pod on neuropathy if you're interested. As well as we go over a few seizures here, but many seizures, especially in adolescence, we cover in other brain pods. All right. So here's what we're going to try to cover. Just a little bit of an introduction of a variety of classes of neurological disorders. A good place to start always is just thinking about development.
So I'm going to interrupt
a little
bit
I
and
love it.
Just give a little plug.
Yeah.
So the nice thing about pediatric neurology, if you want to just go back
slide, give it to me.
Is that in general, the kids are relatively healthy, so we're dealing with just neuro disorders. For those who are considering peds neuro as a career. And
so they don't have 40-pack year history of smoking
yes,
yet?
And they don't have diabetes, and they don't have a lot of other comorbidities that we have to worry about. So we're really just honing in on just the neurological disorder. And the other thing is you can make a large impact on their life and their family's quality of life, because if you intervene at a young age, then you can hopefully optimize their success. So go into peds neuro.
And some of the very, just a plug at the very, very early. Some of the things that we're doing to help preserve the brain in the NICU is just mind-blowing. So very, very cool. All right. And one more, and another plug, and I'm not even a pediatric neurologist, is the kids' brains have such incredible plasticity to recover. So you can have, if I were to have a dissection and a massive stroke, I'm in deep trouble. If you're 3 or 4 years old, it's just amazing how much kids can rewire their brains essentially.
Yeah.
So
in fact, neonatal strokes are pretty common, and these kids still walk and talk even though they can have a large MCA stroke.
Right, and a skilled observer might not even be able to identify them. All right. That all being said, let's go back to the very beginning of how the central nervous system forms. Neurologists are, as we will see in slides later, we're essentially dermatologists. We come from the ectoderm. And the ectoderm folds, and it begins to close at about day 21, and then simultaneously the neural tube is closing anteriorly as well as posteriorly. It closes anteriorly sooner than when it closes posteriorly, but what this means is that if you have a failure of closure, you can end up with these neurulation disorders. And so this first picture here is a picture of complete failure of closure with anencephaly, and then in partial closure of the anterior neuropore, you end up with an encephalocele.
Yes.
Okay.
So it's just very important that pregnant mothers know that they're pregnant, because this is such an early stage of life that you have no idea what they're being exposed to if you aren't careful as a mom.
And so mainly folate? Is it beyond? So we know about folate supplementation mainly for this.
Yes.
Other risks.
And then just avoid drinking and smoking. But sometimes at that early stage,
very difficult.
Women don't know that they're pregnant.
Right. And then deficits of posterior neuropore neurulation is myeloschisis. Did I pronounce that right?
Yes.
And that's a complete failure of closure, and then partial failure of closure is myelomeningocele, commonly referred to as spina bifida. There's a variety of variations to this depending upon how severe it is. It can be as simple as just a tuft of hair and a dimple, right?
On the outside.
On the outside of the
yes.
skin. Conversely, you can have involvement of nerve roots cord. I should say nerve roots, lumbar sacral nerve roots, and sometimes it's just meningocele with the cord and cauda equina are normal.
So anytime you see a baby, don't be afraid to take the diaper off and just to take a look at the bottom. And if there's any concern that you can't see the bottom of the skin, if it's a dimple or hair tuft, you have to make sure you look. That's the biggest mistake that people have if they miss these, but you just look. And if there's any concern, it's very simple to get, at least first as a screening, is an ultrasound.
And if it's missed, what will happen is there'll be failure in lower motor neuron function, right? With bowel and bladder development too, probably.
It just depends on how severe it is, but those are all risks.
Okay. Moving along, so there's deficits of neuronal proliferation, so you don't have to spend too much time thinking about CNS development before you just are amazed by all that happens in development. So you have billions of neurons that start in development of the paraventricular zone, and we'll show you a picture of that in a moment. And there's this period of time during development where these neurons massively proliferate, and if you have a failure of proliferation, you end up with microcephaly. And there's numerous genetic disorders that can lead to that. But also the torch infections. So these are toxoplasma. O is often referred to as other, which I think is mainly syphilis. R, rubella, CCMV, and H, HSV. Others to think about?
No, those are the big ones.
Those are the big ones.
Yeah.
Numerous genetic disorders, which we won't get into all of them. And then macrocephaly, too large of a head, Fragile X syndrome, tuberous sclerosis, fetal alcohol syndrome. Any others to mention?
I would say those are the big ones, but most importantly, just remember to measure the head.
Yeah.
And not just measure the head, but if for some reason your measurement looks odd or very different compared to the scale, just to look back at the history, because pediatricians always measure the head too.
And that's where these graphs come in. Very helpful.
And if the baby's head looks odd,
mm-hmm.
shaped, more triangular or flat, sometimes there's reasons for that, but other times it may be because some of the sutures are closing too early and they may need further evaluation. But grossly, one should know what a normal baby looks like, and then just don't forget to measure their head.
Got it. So neonatal neurology, so this is, we're going to talk about germinal matrix hemorrhage now, which is a common problem in prematurity. So as we were mentioning before, so here is a coronal slice of the brain. This is the lateral ventricle here. And this is the germinal matrix. This is where all of your neurons, or the vast majority of your neurons, your cortical neurons anyway, originate. This region is highly vascular early in development, and these neurons multiply and then they migrate radially out to their final location here in the cortex. This germinal matrix is intact until about week 32, give or take?
I would say that after that, risk of injury is less, but there's still risk. And the one thing I want to point out is that the density of neonatal brains, or premature brains I should say, is extremely soft. If you've ever seen it, if you've ever felt it, it's almost like soft jello before it becomes hardened. Mm-hmm. And so anytime a premature infant is exposed to stressors, whether or not oxygen has decreased or CPR is done or there needs to be any kind of meds or antibiotics, anytime there's any type of stress to the whole body, that area of the brain is at risk for injury.
Got it. And here's a couple of pictures of what that looks like. So this is a postmortem picture of a neonate born early, and you see multiple hemorrhages here. You see a small probably grade 1, grade 2 germinal matrix hemorrhage over here on the right side. On the left side, you have extension into the parenchyma, you have expansion into the ventricles, which I believe makes it was a grade 4.
That would be a grade 4, yeah. So
Yep.
once it goes beyond the germinal matrix into the ventricle, or even just enlarging the ventricles, that they're all now called interventricular hemorrhages as opposed to germinal matrix hemorrhage.
Got it. But this is not how we usually see them. How we usually see them is we do an ultrasound. You do not need to do, vast majority of times, you don't need to do a CT scan or MRI, because ultrasound, because the skull hasn't ossified yet, you can get a really good picture.
Well,
of
and
the
then
brain.
the anterior fontanelle is open too, so
Oh yeah, good point.
technicians have a window into looking at the brain.
Good point. And so kids who have had these hemorrhages are at high risk of cerebral palsy.
Yes.
Let's talk about kernicterus, which is not a condition that I know a lot about, or I don't have a lot of experience with.
And I would say most of us in the U.S. don't have a lot of experience with it because of the fact that there are now protocols that general pediatricians follow where we check bilirubin levels. So if one were to see kernicterus, it'd probably be in an immigrant or someone who, was born somewhere else.
Or just not access to adequate medical care.
Yeah.
Yeah. So, but when kids are born, sometimes their liver is not quite yet functioning, and so they can have an excessive amount of bilirubin, which can lead to deposition, particularly in the extrapyramidal circuit, and this can result in movement disorders such as athetosis, which we went over in the movement disorder brain pod. It can also result in hearing loss because the cochlear nuclei are very vulnerable to hyperbilirubinemia. The kids look jaundiced early on, and they'll have delayed milestones and poor feeding. The treatment, most nurseries are really on top of this. They'll just use phototherapy, which helps convert the bilirubin peripherally just through the ectoderm. And then in extreme situations, severe cases, you can use exchange transfusion right through the umbilical cord. Moving on to chromosomal disorders, so we're going to talk about two in particular, trisomy 21 as well as Fragile X syndrome. When I think about trisomy conditions, Dr. Wang, I think of that a lot of chromosomes can result in trisomy. It's just that the trisomy 21 kids tend to survive.
Yes, that's correct.
So it's trisomy 21 is maybe the most mild, other than I suppose a triple X syndrome, but the most mild trisomy syndrome, so they survive.
And as a culture, many of the developed countries are putting off having children until later,
Yep.
which increases their risk in giving birth to a baby or child with trisomy 21. And so the frequency and incidence of this disorder is seen much more now than it used to be.
Yep. When I think about Down syndrome, I just try to remember that there's just incredible variability in terms of the consequences. Cognitive impairment is from mild to moderate. I'm sure pretty much everyone has met a person with Down syndrome. Obesity is a problem. Short neck, macroglossia. It's because of the large tongue that they have increased obstructive sleep apnea risk. Cardiac abnormalities. One pearl to note is that the amyloid precursor protein is located on trisomy 21, so they get an extra dose of this, and because of that, they get at high risk for Alzheimer's disease. Any other thoughts on trisomy 21?
Just to be aware, they get the early onset Alzheimer's. So I'm talking early 30s.
Yeah.
Not you would normally think in the population is over 50, but these are in their early 30s. And then to realize that these children are now living longer, so they are living past 50. So not only are they seen by pediatric neurologists, but adult neurologists will need to be seeing and taking care of these patients. And the community has to be aware of them too, because there, again, are more people with this chromosomal disorder.
Absolutely. Moving on to Fragile X syndrome. So Fragile X syndrome occurs in boys because it's an expansion of the trinucleotide repeat on the X chromosome, which is the Fragile X mental retardation 1 gene. It results in this classic facies of a long, narrow face, large ears, hypotonia. Cognitive impairment, probably pretty reasonable to state, similar to trisomy 21, with the caveat being that there's often a high burden of autism in these kids.
Yeah, and a lot of these kids are missed, but the two aspects I always look for is the long face and the large ears. It's a pretty easy test to obtain, so I would say that any kid who comes in with autism and developmental delay or cognitive delay, it should be easy just to test it.
Got it. Developmental milestones. Once you're a parent
Yes.
yourself. It's kind of you kind of mark everything against your own kids. But just be aware of the resources out there, in particular the Denver 2 developmental. But when you think of important gross motor or language milestones, what immediately pops into your head, Dr. White?
So the three that I always keep in my head is they should be sitting on their own tripod sitting at 6 months. They should walk by 1 year. And then they should be putting 2 words together at 2 years. Now, give or take a few months, boys in general tend to be a little bit slower, but those are sort of the markers that I use in assessing grossly what their development is like.
If there was probably one thing we really want you to be aware of, all physicians need to be able to recognize non-accidental trauma, child abuse. And the most common thing we see in neurology is the shaken baby syndrome. It's right up there with a spiral fracture. It's just highly indicative of child abuse. It results in even just shaking for a short period of time can result in retinal hemorrhages, subdural hematomas, fractures. As Dr. Wang mentioned, the brain is just not developed enough yet to handle this whiplash-like response. And so what this often looks like is you can get, so here's a picture of the normal sutures, but here's a fracture in the skull. But more importantly, what you're seeing here in this MRI scan is you are seeing you're seeing bleeds of varying ages. So this is an old subdural hematoma here, and the bright blood is a new subdural hematoma. They get diffuse axonal injury, they get retinal hemorrhages, and then you're looking for evidence of previous injury.
Yeah, so one thing to keep in mind is that a pretty common age group that this can present in is about 2 months to 4 months, sometimes up to 6 months. And a lot of parents or people, caretakers who are taking care of this age group don't realize that some mild shaking can actually cause quite a bit of damage. I mean, there has to be a certain amount of velocity.
Right.
But this is also an age where infants cry often. And
parents get more frustrated.
Yes, parents get more frustrated. The other thing to remember is that if a child or a baby comes in earlier than 2 months, so let's say they come in at 3 or 4 weeks of age, is that it might not be shaken baby. It just may be that they have subdurals from delivery.
Okay.
Let's say they had a really hard delivery, and so that's actually not an indication of a shaken baby. But low threshold to screen, and we pretty much, anytime we have concern, we do a full workup because we have concerns.
Back to development real quick, because we're going to be talking about neurocutaneous disorders. As we mentioned, neurologists are in effect dermatologists, because we deal with tissues that stem from the ectoderm. Surface ectoderm becomes the skin, teeth, lens, and cornea. The neural tube becomes the CNS, and it's the neural crest that becomes the glial cells, microglia, astrocytes, oligodendrocytes. They become peripheral neurons, and they become melanocytes. So it stands to reason that you can have genetic disorders that result in both CNS problems as well as skin problems, and that those conditions are going to be discovered by pediatricians. And the two that we want to talk to you about are neurofibromatosis type 1 as well as tuberous sclerosis. Neurofibromatosis type 1 is autosomal dominant, and it is the most common genetic disorder of the nervous system. And here's a couple of things that you see. You see these classic cafe au lait spots, as well as axillary and inguinal freckling.
And some of
yeah.
that doesn't appear until older.
Oh, okay.
So
Okay.
they need to be tracked.
Oh, okay. That's good.
The skin manifestations will increase especially when they start getting through puberty.
Okay, I didn't know that. What about neurofibromas? These are the neurofibromas here.
So these also can increase over age. I don't see this as frequently as the cafe au lait spots.
And then the USMLE, they love to ask about leash nodules, which are these iris hamartomas, which are these little spots right here. That is a sine qua non of neurofibromatosis type 1. And probably what's most relevant is that they are at risk for numerous CNS malignancies. Optic glioma is considered the most common. Any others that you think about?
No, but even though they're at risk, this particular neurocutaneous disorder does not require one to image them every year.
Okay.
So, for example, in tuberous sclerosis, those kids we will image every year. But in neurofibromatosis, generally we will take a couple of images. Now, if they have an optic glioma, that's a different situation. But if they don't have an optic glioma, we don't generally expose them to sedation that is required for imaging until there are some neurological findings.
Got it. On to tuberous sclerosis, also autosomal dominant. Common because of the tubers, cortical tubers, which I'll show you a picture of in a minute. They are at high risk of seizures. They get these hypopigmented macules, often look like an ash leaf. Do you see these when they're kids?
Yes, you can see them. And you're supposed to have a blue light in the clinic.
But
for the most part, these can be seen as long as you know what you're looking for.
Yeah. They get facial angiofibromas, adenoma sebaceum. Is this more of an adult manifestation?
Yes, definitely more in the teenage years you'll see these.
Got it. And this is what the picture looks like. These are the cortical tubers, hence where the name comes from. But in addition to that, they have also, like NF1, they have numerous CNS malignancies. What I found was astrocytomas are most common.
Yes, and the big one is the SEGA, the giant cell astrocytoma, that you have risk that could block off CSF flow.
Okay.
The one thing I want to point out about tuberous sclerosis is that the clinical manifestations can be extremely varied. So a parent can have tuberous sclerosis and not know it and be in a high-powered job and have a child who is severely affected.
Okay.
So the phenotype is very, very different. And there have been situations where we have diagnosed one of the parents after evaluating the child.
Sure. You mentioned imaging these patients every year. Is that a MR of the head? What do you usually
MR
do?
of the head, and then in general, if they're going under sedation for the MR, we'll also MR the kidneys. They need
because
of cysts that occur, and the.
I'm at a loss here. You're looking. We're talking about the renal system now. We are in deep trouble.
Pause for a second. Let's pause for a second. Let me look it up.
That's okay. Is cardiac tissue involved?
So cardiac rhabdomyomas occur usually in the first year of life, but those usually involute.
Yeah.
We check. We always send them to an ophthalmologist because we worry about, again, very similar to hamartomas, tubers, they appear in different parts of the body. So in older in adults, particularly females, we have to worry about lungs. Okay. We have to evaluate the kidneys because not only do they have cysts, there's a term for it.
Are we talking polycystic kidney disease?
No. There's a term for it.
All right.
Can we pause for a second?
There's no pausing here.
Pause?
There's no pausing. We just roll through this. We are live. Consider this live. So anyway, we can look that up. I can also post this in the comments later. All right. Poor Dr. Wang. She's going to look that up while I am going to go start with attention and autism spectrum disorder. So this is I lump these two together because they often present. Okay, here we go. We got it.
Renal angiomyolipoma. So
Done.
that's why.
I love it.
So we have to worry about those lesions.
All right. I love these discussions because they give students an insight in terms of that which is immediately available on the top of our head and that which we know is important, but we can look it up. All right, so let's talk about ADD as well as autism. These often present in preschool, elementary school age. So 5% of school-age children hit the attention spectrum somewhere. Boys more than girls. Symptoms need to begin before age 7. And one way I think about this is the impairment needs to be more than just in one area of their life, right? It can't be just at school. They also have to have dysfunction at home. They need to have dysfunction amongst their kids, amongst their friends. Any other thought on that?
No, I mean, that's the big part of it, is that it has to be in multiple realms of their life.
Okay.
And the question always is whether or not it's something that is just sort of immature brain and development, or is it actually a disorder? And then the real question that we get posed is whether or not they should be medicated.
Right.
And very controversial, but I will say, for the most part, for the patient population that I see, because it's comorbid with epilepsy, is that in order for the child to function and to pay attention in school, they sometimes need their medication. And then, in fact, in order to be a part of the family unit, on weekends when they have family functions, they need to be on meds too. But it is a little bit dicey when you get into the mild areas, and then you have to worry about high schoolers who all have benefit from medications, even though they might not have the diagnosis. And whether
stimulants are performance enhancing, right? I mean, in fact, with caffeine, cheers. There it is. I mean, these are stimulants that improve attention. Okay, and we just kind of mentioned a little bit, since we're talking about medication here. What is the explanation for this condition? My understanding is that it is some degree of hypofunction in monoamines, dopamine, and norepinephrine. So then, of course, the treatment can include stimulants as well as behavioral and occupational therapy.
And we usually think of the frontal lobe as sort of the higher order area that has more function in executive decision making, or just a higher order function. And if you think about it, though, in adults, they're still myelinating, particularly in males. They're still myelinating at up to 25, 30 years old in that frontal lobe. And so that's why I have to wonder sometimes if the kids are exposed to environments that now expect more out of them because of the fact that we have so much information and knowledge that are expected of the teachers in the elementary schools, that it's also difficult just as at their regular developmental ages to learn that much information. And
to sit still through it all.
And the frontal lobes need to mature to a certain extent. And these medications help they activate the frontal lobe in order to help increase their amount of attention.
Okay. Which is why, paradoxically, a stimulant actually helps calm someone down with an attention problem. Let's talk about autism a little bit. So this is a persistent impairment in socialization. It starts before age 3. Again, boys more common than girls. The pathophysiology, for the most part, is unknown, with one very big exception, which is that we are about as certain as you can be in science that vaccines do not cause autism. Which is not to say that vaccines themselves don't have their risks to them, whether or not it's, as we'll talk about later, ADEM, whether or not it's Guillain-Barré syndrome, but we are fairly certain that they do not cause autism.
So for autism, in certain circumstances, so for example, in tuberous sclerosis, you have a high risk of autism. So it's not that, it's just autism is an umbrella label.
Syndrome.
And so so it's not that we don't know what causes it, it's just that there's many, many reasons that cause it.
Fair enough. Yeah, okay. So the deficits in 3 areas: reciprocal social interaction, communication, as well as repetitive compulsive disorders. There's some descriptions of them. These here: lack of interest in shared enjoyment, lack of imitative play, and then stereotyped motor activity. So when you're examining, looking at a kid with autism, what are you thinking of when you're
So
looking
I
at them?
usually just simplify it and say whether or not they have eye contact, and that's even with mom and dad. And
Okay.
do they play more with inanimate objects? So are they going to play with their Legos more than they want to play with a friend, or even they won't always even seek out a hug from mom or dad. So that's the eye contact part of
Okay.
it. The second part of it is that they have poor language skills. And then the third part about it is the repetitive movement. So this in young children is typically seen as hand flapping or circling around, a lot of this type of movement, head banging, repetitive sort of self-stimulatory or self-regulatory type behavior.
Treatment. Again, behavioral occupational therapy, sometimes just getting them behaviorally conditioned to look at someone when they're talking to them, right?
So in fact, I think there's a company that's even using Google Glasses to try to teach these autistic kids to not necessarily they can't comprehend another human face and think of it as a social interaction, but at least to train them to look, even if it's at their nose or their eyebrow, so that they have a better chance of sort of assimilating into society because they have learned.
They're conditioned. They've just conditioned them.
In a way.
Okay. Medications do play a role, as far as I understand, mainly in the role of symptomatic treatment. These kids often have tics. They may have compulsions, self-harming behaviors. Let's talk about pediatric epilepsy a little bit. Probably most common, one of the common is febrile seizures. So when before the age of 5, it's very common for a child to have a seizure due to a high fever. Up to 1 in 20. Two types. By far, most of these are just simple febrile seizures. They're short duration. They last less than 15 minutes. They don't have any focal features, meaning that they don't have an aura. They don't start clearly on one part of the body. And these are unlikely to progress to epilepsy. And really, the main issue is just reassurance.
Yes.
Okay.
There's usually a family history too.
Oh, is that right?
Yeah.
Complex seizures. Dr. Wang, how would you if you saw 10 febrile seizures, how many would you guess are going to be complex and you need to do a workup and consider treatment?
So the truth is, I don't see any of the simple.
Oh, okay.
So and that's a good thing. I shouldn't be seeing them because the general pediatrician
that makes sense.
them. So for most of the patients I see do have complex febrile seizures.
Oh, okay, got it.
Yeah.
And so then you'll do a picture, you'll do an MR. And an EEG, and if there's an abnormality, then you start an AED? Or?
So I don't always do the MR,
Okay.
Again, because I have to sedate them for the imaging.
Oh, okay.
So I start with an EEG, and if the EEG looks okay, then sometimes, and let's say their development is fine and their exam is fine, then I usually leave that alone. But if there's concern, then I'll work on the MRI.
So we're going to talk about absence epilepsy here. We actually already showed these videos before on during the seizure and epilepsy brain pod, but I'm gonna mute these and I'm just gonna play them and let Dr. Wang kind of narrate what she's seeing. This video was posted on YouTube by this dad who just had gone to see the pediatrician or pediatric neurologist who showed that he was able to induce these absence spells with hyperventilation and wanted to try it again at home and then post it.
So a couple of things about absence seizures or absence epilepsy is that these kids can often be mistaken for having ADD.
Yep.
And they may be on stimulants and they may have tutoring or they may be in special ed because they are told that they zone out or they're inattentive. And so the diagnosis can be missed for
there he goes.
There he goes. It can be missed for years sometimes. The other thing is, so in this situation, probably 45 seconds into it, he had a event. Now, the absence seizures can be as short as 3 seconds sometimes.
Let me show you another one. This is a girl of several here. This girl. She has several short ones. They show her actually at school too. A little bit later. There it goes. And then.
And so you see how mild they are. I mean, if you're a parent or a teacher and you just look at some other kid and you turn around, they may be out of it. But if they've missed what they've been taught, maybe an alphabet letter or something like that, they are then considered to be inattentive or ADD as opposed to actually having absent seizures.
Let's quit sharing. Got it? Yeah, they're sharing.
Some of these are a little bit more obvious. They are associated with some blinking and sometimes some grunting or clicking in the mouth. But because they're so short and sometimes they happen more at school as opposed to at night, they're oftentimes missed for months and again sometimes years.
Let's talk about breath holding a little bit. So these kids at about a year. What is the range?
I would say about year to 5 years.
Okay.
Even a long younger than a year too. And these kids are scary.
Oh, they're for parents as well. So I found this video, and what's really impressive here is that at the end of this event, he will go into kind of an extensive tonic posturing, which then tends to make everybody concerned.
Okay, so the one thing to know about these, there's two types of breath holding spells. One which is associated with more cyanosis, where they turn blue. The other ones are associated with more pallor.
Yeah.
But they're usually triggered by either a sort of an emotional response to something, where a parent might say, no, you can't play with that toy.
Right.
Or a more painful response where they may bang their funny bone on their elbow or something like that. And then this triggers this. And parents don't really know how to react because all of a sudden their child looks like this, where they're non-responsive and holding their breath, and then it can go on to have, in severe cases, can sometimes have a little bit of convulsive activity afterwards.
Got it. Let's just play it here.
It's all right. You're all right, buddy.
And you see the stiffening, almost a pistonic. Oh, there he goes. He breathes.
Yeah.
And for a lot of adults, parents, this is very difficult because if they respond this way to disciplining, then how do you discipline your child? But again, there is generally a family history of this too.
Yeah. Welcome to parenthood is all I have to say.
So you didn't know that about pediatric neurology?
What's that?
Is that we're not just taking care of the child, but we're taking care of the family.
Oh, yeah. It's the parents. Yes. Yeah. This is, you're mainly taking care of. That's. Let's talk about brain tumors real quick. Just a couple points to make, which is that CNS malignancies are tragically the most common solid tumor type in children. It's the second most common malignancy after leukemia lymphomas. They usually occur in the posterior fossa. That means brainstem cerebellum. That differs from adult malignancies, and the three most common pathologies I have listed here: astrocytoma, medulloblastoma, ependymoma, and the MRI picture there is of astrocytoma. And one thing to just note is that this is a very big third ventricle, so there's clearly some degree of hydrocephalus from blockage of the cerebral aqueduct.
So just the most important aspect of CNS tumors is to know that headaches is probably one of the first complaints, but a lot of kids don't know how to tell their parents they have headaches.
Okay.
And then the other problem is headaches are very just common.
Yep.
But if something is waking them up in the middle of the night, if the headache is waking up in, let's say, 3 or 4 in the morning, and pretty much consistently, then you have to worry about tumor. And then if they're vomiting too.
Okay.
So.
And the emesis center is in the brainstem, so that makes sense. Let's talk about infections. So. Usually these are not taken care of by pediatric neurologists, but you get bacterial meningitis. The different types occur at different ages. Newborns, group B strep, E. coli, listeria. 3 months to 3 years, strep pneumo, Neisseria, H. flu, and then adolescence to young adulthood is strep pneumo, Neisseria, and mycoplasma. What we're looking at here is the non-blanching rash from Neisseria. So one of the things I remember from my pediatric clerkship was the very low threshold we have for performing a lumbar puncture on a newborn if they have a fever and are less than 6 weeks old, because we're just not able to dismiss or cavalierly dismiss something as maybe being a sinus event or a pulmonary event. We really have to make sure that it's not meningitis.
Well, the other thing is babies just don't have a huge repertoire of movements and
Okay.
so in a child or an adult, you can look at them and you can just see in their face they look well or they look sick. But in a baby, they don't move a lot and they can't tell you I feel sick and I feel crummy or anything, and they can't tell you they have a headache. The other thing is, at this age, their anterior fontanelle is still open, and so if there's any type of swelling or increased pressure, they have a pop-off valve, so their sutures are not quite closed, their anterior fontanelle is open, and so they're not going to have any kind of meningismus or any type of those types of signs that you would have in a child or an adult. And that's why you have a very low threshold to go ahead and tap. They're pretty easy to tap, and because you should always, in any case of meningitis, treat if you even suspect it. The prognosis is significantly better if you have early treatment.
Yep, and we'll go over treatment in just a moment. Important to another infection to talk about is HSV encephalitis. This is for newborns. This is acquired during the delivery if the vagina has active lesions. Really important to catch. This is one of the most important pieces about good prenatal care. Untreated mortality is very high. This 70% is the number I have here. I don't know if that's been,
I mean, and morbidity is extremely high too.
If they survive.
Yeah.
And it's easily taken care of with just a cesarean section. Different from HSV encephalitis in older kids and adults, the pathology is diffuse. This is just basically showing that T2 changes diffusely throughout the brain. Conversely, if this is not a newborn HSV encephalitis, you get this common location in the bilateral temporal lobes, and it's usually HSV2, latent activation of latent HSV2 virus. Treatment. So if you are looking at an individual child who has likely meningitis, you do conventional empiric antibiotic therapy, which is ceftriaxone and vancomycin. Corticosteroids are helpful. They help decrease the inflammation that is causing much of the damage, decrease some of that tumor necrosis factor. If you're talking about the very young and the very old, you add ampicillin for listeria.
And I believe actually under the age of 1 month, ceftriaxone is no longer used. It's cefuroxime, and it has to do with bilirubin, biliary sludging. And so that is something that's post my graduation of residency. Now.
So ceftriaxone can increase bilirubin sludging.
Not bilirubin, but biliary sludging.
Biliary. Does that put them at higher risk of kernicterus then?
That's a good question.
A good question.
Yeah,
all right.
But it's after a month of age, so it's not usually that risky after they've been a few weeks old, because by that time they're already eating and they're already peeing and pooping, so they should be clearing their bilirubin.
Got it. And this is an emergency. Don't wait to treat. If we're talking about encephalitis, main is acyclovir. You want to make sure you cover HSV. Also an emergency. Don't wait to treat. Just a couple more conditions to talk about. We mentioned ADEM and the demyelinating brain pod. Just a reminder, this is an acute monophasic inflammation of white matter. It's often seen after a vaccine or an infection. It is really frightening for parents and families to go through. The good news is that this is inflammation without underlying myelin or axon damage. So that when they recover, they usually recover completely without chronic deficit. Treated with corticosteroids and plasmapheresis, mainly just to accelerate the recovery. And then we're going to move on to motor movement disorders. We're going to talk about two. We're going to talk about tics as well as Sydenham's chorea. Tics, really common, stereotype, repetitive, non-rhythmic movement disorder. They are partially suppressible. These kids can feel them coming and they can suppress them for a little while, and then until they just become overwhelming and they have to play them out. Let me show an example. I'll show a couple of examples, and we'll just get Dr. Wang's comments on them as we go through them.
Hello, baby.
This was the one that let us know there was dark magic in the
There you go.
forest when they
Oh,
found
and
you.
the mouth opening.
Hey, it's showing there's dark magic
There's the
right
mouth
here.
opening. So it's good to know that these are very, very common. Normal kids have them. And they'll come for a few months and they'll disappear, and then sometimes they evolve into a different type of tics.
Okay.
And more importantly, we just sort of reassure parents, but if it becomes socially impairing for
Yeah.
the child, that's when we seek intervention.
Other comment, like blepharospasm, so blinking.
Blinking, yeah.
Blinking's a common one. This is a wonderful video. What this shows is, as you'll be able to hear the mom talk to her daughter through this, and what she's trying to get her daughter to do is to explain the urge, the feeling that is causing her to have these tics, and then what happens after she does the movement. And what she explains is that by making the movement, the discomfort, the urge is taken care of, but it's not fully resolved. It's just decreased by half. And we'll go ahead and show these motor.
I think that's the perfect word, urge, what they feel.
Still got feel sensation here. Is it getting smaller, the sensation at the scapula there? Every time you do the movement, the sensation is getting lesser.
But now, usually last time the sensation is getting half less, like
After each movement, the sensation becomes half less.
half
Now?
less. But now when I make another move again, the sensation only tiny move a bit only.
Is that great?
Yeah, no. So what I will say is a lot of kids, especially if they're very self-conscious about it, they will hold that urge until the bell rings, and then as soon as the bell rings and everybody gets up from their desk to move to the next class, then they'll do their tics or their arm or their jerk or anything like that, and they'll just do it for about 30 seconds, and then they'll feel a breath of relief, and then they can move on.
Got it. So talking about how do we classify these into disorders, so as Dr. Wang mentioned, motor tics, vocal tics in and of themselves are pretty common. They often don't require treatment. If you are going to treat them, this is what I have: clonidine, dopaminergic blockers. Any comments on how you approach this?
Yeah, so in general, depending on how severe the tics are, we would prefer cognitive behavioral therapy.
Okay.
But that type of therapy requires consistent attendance and also a commitment over 8 to 10 weeks, and also a maturity in that child to have body awareness.
Okay.
Clonidine is a very easy treatment to provide. It doesn't always work, and because it's also a blood pressure medication, I do worry a little bit about affecting blood pressure. But it calms the child down. A lot of these tics are brought out by anxiety.
Yep.
And then the dopaminergic blockers, I actually, again, will only prescribe in situations where it's extremely socially impairing, the child is starting to get bullied or anything like that, because I worry about the side effects and ramifications, sequelae of the dopaminergic blockers.
And any agent in particular? Is it Thorazine? Is this Haldol?
All of those.
All of them.
Because you worry about extrapyramidal effects.
So let's talk about Tourette's disorder, which is what a lot of people think of when they think of tics. In order to have Tourette's, you have to have multiple, both motor and vocal tics. It needs to occur before the age of 18, and this is associated with other underlying conditions, in particular OCD and ADHD. Any other comments on Tourette's before we show a couple videos?
No, I mean, I just think of Tourette's as a very severe tic disorder.
Yeah.
I mean, they're all similar, just manifestations, but this one includes vocal ones.
And here's a guy with you can hear sniffing, you can hear some vocal tics as long as
Do you know that a lot of doctors have tics? So.
Oh yeah, well, and if you can talk to my sister as growing up, it's or I mean how frequently we clear our throats, or I do.
I think a lot of people in high-powered positions have tics, so that's what
go.
I usually tell my patients.
There we go.
Actually.
All right.
Okay. I figured you didn't have one, so I figured. I mean, that's what I thought. So
I think as a parent, these are very, very hard to see and watch your child go through, but they just have to be patient, because they come and go, and it's a way of the body sort of self-regulating.
Now, when people talk about tics, they often talk about coprolalia, the sudden swearing, because it's just so dramatic. It's actually pretty rare, but just an example of that.
So, hey, tell me again about how long all this is. This is. I've had motor tics since I was a child, and about 5 years ago, the vocal tics started, and the motor tics have gotten a lot more intense. I deal with addiction and alcohol abuse as well, and in the past 6 months since I have been sober, it's gotten dramatically worse, unmanageable. Okay. Thank you much.
Yeah, so in children, most of them have not learned all these words, but I will say that it's not uncommon for me to see patients who have little screams or sounds,
Yeah.
and it can be very disruptive, even just in the waiting room, very, very disruptive. And,
Yeah.
and a lot of these kids will grow up with mental health problems because of the self-consciousness.
Absolutely. Final is talk about Sydenham's chorea as a movement disorder. This is one of the reasons why we treat strep throat, is that there are a variety of, do we still refer them as PANDAS? Pediatric autoimmune neuropsychiatric disorders associated with streptococcus. That's what I remember learning
So
them as.
PANDAS is controversial.
Okay.
But the concept behind PANDAS is that it is probably initially an autoimmune process, and then many of us believe that once you treat them with antibiotics, that really should resolve. And if it continues into OCD type behaviors,
Right.
then really it's more psychiatric as opposed to an autoimmune process.
Okay.
But there are neurologists who still think it's a continued autoimmune process.
So anyway, so this is a choreiform disorder. We went over chorea movements in the movement disorders brain pod. I have another picture of a young girl who has this Sydenham's chorea that occurs after a streptococcal infection. It's associated with carditis, which is part of the syndrome of rheumatic fever, and it's treated with penicillin V. The good news is that this is transient. However, it can take a long.
Yeah, it can linger, and then also because the chorea can be drastic or the movement's high amplitude, again, it can be socially impairing.
Yeah.
There, you got it?
Any comments on what you're looking at here?
I mean, just sort of the dancing and writhing type movements. What I would say is that we don't see it, I would say, as commonly here in the U.S. because for the most part, pediatricians are very good about making sure they check strep. The rapid strep test is very easy to check. The schools are extremely efficient. As soon as one kid is diagnosed, the whole class is notified.
Yep.
And so, in general, strep infections are treated pretty quickly.
And that is it, not only for this brain pod, but all of our brain pods. So I want to thank Dr. Wang very much.
Oh, thank you.
This is great. So students will meet you on occasion. So if they do a pediatric neurology
Which they all should.
which they all
Really.
should, even if it's only for your own children later, because it's actually one of the it's one of the fun things about actually having a kid, of your own, is you can actually watch all of these. Oh,
Yes.
look at this. That's the parachute response.
Yes, exactly.
That's look at the toes finally not going down. All of those sorts of things. So steppage response, all of those things. But anyway, thank you very much, Dr. Wang, and everyone else who has helped out. And I look forward to seeing everybody on the clerkship.